do have someone from OASAS on the line. We do have Carmelita Cruz on the line, so I'm hoping, Carmelita, I sent you your audio pin. If you could just give us an update on the draft telepractice regulations and the status of that. I know the public comment period has ended for that, so any news or updates you have, we would greatly appreciate. You've been unmuted.
Hi, this is Carmelita.
Hi.
Great, you can hear me. So the public comment period for the telepractice regulations ended. It's actually been filed for adoption. So on January 24th, which is this coming Wednesday, they'll officially be adopted. So the regulations are posted on the OASAS website under the Regulations tab, and there's also a draft standards document that's posted there. I believe that there are some changes to the original standards document, but that'll be posted along with the final regulation on the 24th. So if anyone has any questions about what is in there, please feel free to contact me or consult the website and you can see the most current version.
Excellent. Thank you for that update. That's very exciting. I'll post that link with the meeting notes when I send those out tomorrow, or actually Wednesday, I'm sorry. OMH-wise, I know that Amy Smith was not able to join us today, but OMH does not have any updates at this time. And I do not see anyone from the Department of Health on the line right now, so we're going to skip past them. And I'll turn it over at this point to our first presenter, which is Dave Wolf of ADK Action. And I'll let him speak a little to the work that ADK Action does, and then he's going to talk about broadband in Northern New York and its importance to everyone on the call today. So Dave, take it away.
Katie, thank you very much. And good afternoon, everybody. ADK Action is a nonpartisan 501c3. We create projects to address unmet needs, promote vibrant communities, and preserve the character of the Adirondacks. Our focal, or headquarters, if you will, is in the Tri-Lakes area. I head up our broadband project, and the goal of that project is universal access to high-speed broadband throughout northern New York. And when I say high speed, I'm talking about 100 megabits per second or faster. Before I start, just to make sure we're all on the same page, when I say broadband, broadband access, or internet access, I'm referring to the same thing. They're all synonymous for my purposes today. In a second here, we've got page. There we go. Okay, second slide. Hopefully you all can see it. Governor Cuomos quote at the top, a recent quote, broadband is today what electricity was nearly a century ago. It's interesting, and one sort of side note on that is in the 1930s, the U.S. Department of Agriculture was a source of federal funding for getting electricity to the Midwest and all the rural farms, et cetera, throughout the United States. And as it turns out, as we're talking about broadband access and broadband expansion today, the USDA still is the source of funding. That's give you a little history there. What you're seeing is a screenshot of the New York Connects webpage, which is an online resource directory, excuse me, to find home and community-based services offered by the state of New York. If you were able to click on the health button, many of you would be familiar with the fact that a person could find information about health insurance, they could apply for disability benefits, et cetera. As Katie mentioned before, I want to talk a little bit before I get into the details about where we stand with broadband expansion in the North Country is, why. And it basically, the internet touches all segments of society, as I'm sure many of you are aware. Older adults in the North Country, you've got physical isolation, inadequate transportation, harsh winters, and all of that broadband can help address. Businesses, small customer bases up here, high advertising costs, sometimes exist in an area of a failing economy. On a more positive note, broadband gives them access to be able to compete regionally, nationally, and in some cases even internationally. Education. 1/3 of the students in the North Country, and it's increasing all the time, require broadband to complete their homework assignments. Over 80% of job seekers use online job searching now. Seasonal residents in the park, you may be aware, there's something on the order of 45% of all residential real estate in the Adirondack Park is owned by somebody with a zip code outside the park, vacation home, seasonal home, what have you. And if we can get those folks to stay longer, even move to the park and telecommute, it would really make an economic difference. As a matter of fact, I'm a prime example. I was born and raised in Saranac Lake, but left after high school and after college, had a 31-year career with IBM. My last 15 years with IBM, I was in IBM consulting. I could have lived anywhere in the world. All I needed was access to broadband and be close to an airport. So let me summarize it by saying, if you're familiar with Maslow's hierarchy of needs, I'd like to say that that should be updated, that the basic part of that hierarchy, which talks to the need for air, food, and shelter, I would submit now you have to add broadband to that as well in today's world. In January 2016, New York State launched the new New York State Broadband Program. And the goal of that program is to get universal access to this 100 megabit speed I was talking about to all residents in the state by the end of 2018, with a minimum of at least 25 megabits. That's the new federal standard for high speed in some of the more remote areas. And to size that, 100 megabits would allow you to download a high definition movie in something on the order of about 11 minutes. Versus in excess of 2 hours if you were at 6 meg or lower. The state came up with $500 million from a bank settlement. They're looking to get private industry to match that investment. And they've been able to grow that fund to actually $670 million using some funds from the federal government called Connect America funds. I'll talk more about that later. Suffice it to say that in 2016, a world leader in broadband econometrics, the Strategic Networks Groups, ranked New York State #1 in the nation for broadband activity and investment. The program uses something called a reverse auction, whereby a provider would submit an application to connect a certain number of households, they call it, units, in an area, and they would put a cost on that. You do the division, figure out what it would cost to pass each household, and the provider that does that for the least cost would potentially win the auction. The technologies involved are basically fiber to the house, cable coax to the house, and in some cases fixed wireless. The problem there is you need basically line of sight, which is not great in the Adirondacks, but it's good for the last mile connections. As people talk about it. So that's the program. Was launched in beginning of 2016. There have been 2 phases so far in that program. The state has paid out something on the order of about $265 million of that $670 million so far. So there's slightly over $400 million, my math serves me right here, that's to be passed out or granted in phase 3. What I'm showing you on this chart is the 13 counties in the North Country are in 3 of the 10 REDCs, and this just simply shows the number of eligible units that were awarded monies. In other words, in phase 1, in our region, we had 15,207 households were to be connected for a cost from the state of $25 million. You do the math on phases 1 and 2, and the good news is the North Country received over 45% of the money that was awarded. The bad news is that really also suggests that we are probably the one area of the state that has the most need. Phase 1 ran from February through August of 2016. Phase 2 ran from August to March of 2017. Phase 3 opened up in March of 2017 and is not been announced yet. We're all waiting patiently for the announcement of Phase 3. When Phase 3 was announced, the next chart showing you a very colorful map of northern New York. You can see faintly the outlines of the various counties. And this is showing It's information provided by the New York State Broadband Program Office. The URL of the program office that I'm circling down here is where this information resides. This is actually a Google Earth shot of northern New York. And what you're seeing in the four colors is it's basically the orange, for instance, is highlighting the census blocks. That's the way the FCC actually figures out whether you're covered or not with broadband. So everything in orange suggests that those census blocks are areas where people are what's called unserved. They have either none or less than 25 meg connections. Underserved in blue is very little of that in the North Country. That means you have a connection between 25 and 100 megabits. Everything in purple is the Connect America funds. This is money that Verizon turned down. And the good news is the state officials were able to convince the FCC to keep that money in New York State. It was added into Phase 3, and that's why there's over $400 million available in Phase 3 to be allocated. The last is green, additional service areas. Suffice it to say, that is a good news is we don't have a lot of people in those areas. It's basically a sort of a catch-all bucket, I'll call it. And I'm actually not going to spend a lot of time on it. You'll see some of the details in a later chart. Spectrum territories were excluded from this phase. What Spectrum is the new company, is the merger of Time Warner Charter. More information about that will be coming up later. This is a summary of basically in the 13 counties in northern New York, all of the eligible households, units they called it, that are unserved. You see, if you look at column number 1, it says unserved, there's 37,624 of those households in northern New York, or 37% of the total in the state. Underserved, we have over 60% of the total, and the Connect America funding, we have 34%. If you look at, there are 62 counties in the state. 10 of our 13 counties are in the top 20 in being unserved. That's the good news, bad news. We have 5 of the top 20 underserved. We have 10 of the top 20 in eligible for CAF funding, and we have 6 of the top 15 eligible units in total in the state. So you can tell northern New York is a major need for connecting people to the internet still. The map I showed you earlier had 4 colors, didn't say a lot. What we did in spring and early summer, we being Barb Rice, Franklin County legislator, Russ Kenyon, Franklin County Economic Development Director, and myself, we met with town and county officials throughout the North Country using maps like this in an effort to convince those local officials to reach out to the providers in their area, working with the providers to have them submit the most robust bids that they could for Phase 3 funding. What you see here is what Russ did is using a sophisticated program, was able to take the data from the state, and for instance, the purple, you see a lot of purple. The lighter the shade of purple, the fewer the number of households in that area. The darker the shade, the more households. So the real dark purple in the center, for instance, there's more than 100 households in that census block. The really light purple, that'd be, say, less than 5. So this was a first cut to show the town officials. The next chart, we then took and cut the counties in a third. So this is actually showing in Essex County. This would be the town of Lewis. And you now see superimposed the actual number of households in this census block. So 21 eligible households. I'm circling over here in the neighboring town of Keene. There's 84 households as an example. So this kind of map was very useful in talking to the county officials, town officials, for them to visually see where the problem was in their towns and counties, so that they could work with the providers, as I said, to try and maximize the bids the providers submitted. That is the sort of real broad brush on the New York State, New York Broadband Program. That's half of the solution. The other half of the solution for getting everybody in the state connected is what you see on the next chart, is at the same time the new New York State Broadband Program was announced, is the State Public Service Commission also approved the merger of Time Warner Charter, but they put requirements on that merger that would cost Time Warner Charter, or Spectrum as the new company is called, about $1 billion of private investment. And some of those requirements are, you see here, that they're going to add 145,000 households on their own dime to their network. They've got about 2 million households in their network now, and they're adding 145,000 over 4 years. They're also upgrading everybody who has a Time Warner Charter slash Spectrum connection today. You actually, not even the end of 2018, today you can, if you pay for it, can get access to 100 meg, and by the end of 2019, you'll be able to get access to 300 megabits. And the pricing is going to be New York City pricing, even upstate. So you see here a low-income service at 30 meg, which, by the way, is higher than the federal minimum for high speed for only $15 a month. This is a map of northern New York. Everything in the sort of blue color is a town with a Spectrum franchise in it. And so you can see that they're pretty pervasive throughout northern New York. There's an issue called Make Ready. It's one of the reasons why the whole process of expansion of broadband takes so much time, is that a person who wants to put, say, fiber on a pole or cable on a pole has to go to the pole owner and basically go through this process that says, I want to do it. The pole owner then has to actually survey each pole, figure out what's going to cost, get paid, and actually do the work to move the lines around to make room for you. It's when Spectrum is doing this 145,000 additional households, they are actually addressing 180,000 poles. And suffice it to say that that large amount of work is not going as well as planned. Initially, there was a major fine that Spectrum ran into. The good news is you've got the Public Service Commission, you've got the New York State Broadband Program Office, you've got the providers, you've got the pole owners all working weekly to solve that problem. And things are now back on track, and Spectrum is actually going to achieve its goal, hopefully by 2020, of adding that 145,000 households. And that begs the question, if you're in a Spectrum territory today and do not have access to the Spectrum network, they have provided a URL, you see it down here, I'm circling it, where you can actually go online and put in your address, and it will tell you whether you are going to be eligible to be added to their network in the next 3 years. So, Katie, that's in summary where we stand. We're waiting for phase 3 to be announced. We're for over $400 million to be allocated to providers. What I'm looking for when that announcement is made is to get information by provider, by how much they were granted, by to connect, X number of customers in Y towns throughout the North Country. We're all waiting anxiously for that information to come out. And I will stop at this point and see if there's any questions.
Excellent. Thank you, Dave. And, when we do get that phase 3 funding information, Dave will send that my way, and I can share that with the group. I do have several questions. The first one is from Lowell Feldman. Lowell, your line is open.
Hi, Lowell Feldman, Castleton Group. Can you hear me okay?
Yes, Lowell.
Yes.
Okay. I was wondering, on this program, is there any allowance for any satellite providers to come into place? We deal with a number of companies that use satellite in their systems and pick up the lowest broadband, but also satellite connectivity. So is there any allocations, especially in the most rural areas, for satellite connectivity to occur, other than the existing broadband spectrum and fiber?
We're waiting to see what phase 3 actually results are. The quick answer is, in general, the speeds we're talking about at 100 megabits, the satellite technology is not capable of doing that yet. When you drop it to 25 meg, you start approaching that as a possible answer. And so, by and large, the focus had been on the 3 technologies I mentioned, not satellite, and it's really driven by the limitations of the technology is the only reason that's the answer.
Okay, and second, the URL site, will that have access to areas outside in the state, but outside the North Country, for example, in Orange, Sullivan, Delaware County?
Yes.
Yes.
Any place in the state.
Great. All right. Thank you.
Sure.
All right, and then we have one more question. I apologize if I butcher your name, but Husna, your line is open.
I'm sorry, what was that?
You had asked a question about Dave's presentation, and I'm allowing you to ask.
Oh no, I just had I accidentally entered the wrong dial-in. I meant to put that in the phone, but I accidentally sent out through the question. I apologize.
Okay, thank you very much. All right, thank you very much, Dave, for that presentation. Actually, there's one more question. I apologize. George, I sent you your audio pin, so if you could put that in, you can ask your question. Just waiting on him to put in his pin.
By the way, Katie, while we're waiting, anybody that has a question, if they just send it to you after the call is over, it's forwarded to me, and I'll try and answer it as well.
Sure. And just so everyone knows, this is being recorded, and I will send out the slide deck after the fact. Dave, if that's okay with you?
Sure.
Okay. Okay, maybe that person didn't have a question. So, Dave, I don't see any
Katie.
more questions. Yep. George?
Hey, Katie, this is Bob.
Oh, hi, Bob.
Yeah, just a quick question. I assume that all of this money is for service providers and ISPs, no end users.
Yes, it's for the service providers to actually bring the technology, be it fiber or cable or what have you, to basically, I'll call it the front of the driveway.
Right. Okay, just checking. Thank you.
You're welcome.
All right, thank you so much, Dave. I am now going to switch it over to our next presenter.
Thank you, Katie.
And our next presenter is Andrew Talal. He is a provider and a principal investigator of the PCORI study, and he's going to speak about the work that he's doing utilizing telemedicine versus usual care for HCV for patients on opioid substitution therapy. So, Andrew, we can see your slide, but you have it showing notes. Can you make it full screen? Andrew, I think if you go to display settings at the top, you're able to change it.
Okay.
Yeah, click swap presenter view and slideshow.
Now I have black.
Yeah, it shouldn't be showing that. If you want, it shouldn't be showing that. Maybe try duplicate slideshow.
Okay, hold on. Duplicate slide swap. How's that?
Yeah, there we go.
All right. Sorry. Okay, so thank you very much. Thank you for the invitation to speak today. And I wanted to update you on our study, which is a 5-year study. So I'll basically review our pilot data and the beginnings of telemedicine or the study, but we won't have actual data till 2021. So the problem, okay, the problem is, so the problem is that hepatitis C is a very frequent occurrence in patients on former heroin addicts. And the issue is that hepatologists or infectious diseases or specialists who treat hepatitis C don't usually go to methadone programs, and patients also don't usually go to liver clinics. And so about 3 years ago, I started a project here to virtually integrate treatment for hepatitis C and to connect the liver clinic with the methadone program using telemedicine. And so this is the model of our study, and I'll show you the results. This is from the pilot study. So patients would come in. We offered them 2 on-site education sessions. Those who had virus, the virus was detectable, would undergo an evaluation, and there's me in my office evaluating a patient in a methadone program in Manhattan. And so methadone is used as a replacement for heroin, and because of its regulation, patients are required to come between every day to every other week. And so it creates a situation where you can really engage the patient right there when they're actually getting the methadone. All of these programs have physician assistants or physicians or nurse practitioners who are responsible for conducting physical exams, and we would see the patients with the physician assistant. We would then document in the electronic health record. DAA stands for direct acting antivirals, and these are the new medications for hepatitis C. If any of you are home on the evening and watch the evening news, you can't miss any news broadcast without an advertisement for at least one of them. And those were then delivered right to the opioid substitution therapy program. And we gave them the hepatitis C medication with the methadone, and would submit bills electronically for these evaluations. So in terms of there were a total of 62 patients. The place where we started the pilot study was in West Harlem. So most of the 61% of the patients were African American. Most were non-Hispanic. About a quarter also had HIV. And then just you can see there the type of virus that they had. Their mean age was actually in the late 50s, and and all of them had virus that was detectable. We did a blood test to see how much scarring there was in the liver, which we call fibrosis. And this is just showing the amount of inflammation and the amount of scarring in the liver. If you just pay attention to the fibrosis stage, that's really the important one. And you can see that the scarring goes from 0 with no scarring all the way to F4 in the pink or the purple is actually cirrhosis. So about a quarter of the patients, about a third, had advanced fibrosis or cirrhosis, which means they've had the disease for many, many years, but just have not been treated for it. And that's really the problem with these patients. I mean, it can take 20 to 30 years to develop cirrhosis or end-stage liver disease once one is infected with hepatitis C. And it's when that scarring occurs that's when liver cancer can occur and the liver failure can occur. So out of the 62 who were evaluated, 45 were treated. 93% got rid of the virus, meaning were cured, which with these new therapies is really what we expect. And one patient had upset GI discomfort and discontinued early. The treatment now lasts about 2 to 3 months, depending upon which treatment regimen is used. And 2 people really likely reinfected themselves. I mean, even though they're on methadone, it's not everybody stops using injection drugs. Well, the goal or at least what we like to say, is that they should use safely. And so we expect that 2 of the patients were reinfected and could be retreated if they had pursued retreatment. We also, because this is a new way of treating patients, we also look to see what are some of the factors that influence whether somebody goes for treatment or doesn't go for treatment. And so the factors that we found that affected who went for treatment were if somebody was married, and if somebody had a psychiatric diagnosis other than depression. And negative factors were obviously not being married or a diagnosis of depression. And really, this is getting to the point of looking at some of the social determinants of health. In other words, how can we begin in this population to start to think about who will take part in this program? If you offer the treatment on site, who will take care of it? We also looked at, and we made a video, and we did focus groups, and we did questionnaires about their reaction to telemedicine. As I said, this was largely a minority, late 50, with a late middle-aged, with a middle age of about 57. And what we found was that there were no technical difficulties with telemedicine, and the subjects prefer telemedicine-based HCV treatment delivery compared to off-site referral, and they cited the convenience and the fact that there's one-stop shopping. They don't have to go out to get their medication. They're already there to get their Hep C treated and the medication for Hep C. They're already coming there, as I said, once daily to weekly. And so they like the idea of being able to deliver it right there. There was a concern about privacy early on. Who would be listening to me? This is an African-American population largely. So there was some concern. Some literature has shown that African-Americans tend to be more suspicious over using virtual telemedicine or telehealth as opposed to Hispanics. But over time, that really resolved. And I think that this points to the importance of the bedside manner, that the method of delivery, whether it's in person or virtual, is really less important than the physician or the healthcare provider. And do they pay attention to the patient? Do they make the patient feel comfortable? Do they make the patient, do they feel welcome, et cetera? So with that pilot study, we started we were funded about a year and a half ago to initiate what we're calling Team C, which is telemedicine evaluation, adherence and medication for hepatitis C. And the goal is really to compare the effectiveness of telemedicine to usual care amongst these patients on what we call opioid substitution therapy, basically methadone. And it's sponsored by the Patient-Centered Outcomes Research Institute. And the secondary goals are to look at treatment initiation and completion rates, satisfaction with healthcare delivery, satisfaction with telemedicine, as well as the socio-demographics. So this study is being conducted at 12, we have a nice geographic representation, 6 sites in New York City, 1 in the Hudson Valley, 1 in Syracuse, 2 in Rochester, and 2 in Buffalo, and very different demographics between the different sites, as well as different effects of the opioid epidemic, unfortunately. In terms of the study, the usual care arm in most places consists of referral. In the telemedicine arm, we do education in both arms. Patients will be evaluated. They get these blood tests that tell us the level of the virus, the type of the virus, and how much scarring there is in the liver. And then treatment will be delivered on site, and they'll undergo telemedicine evaluations every 2 weeks, and treatment until the end of the treatment period. And really, what we're trying to take advantage of is the team that already exists in the methadone programs. So you already have a nurse, you have pharmacists, you have behavioral health supervisors, technicians, substance use counselors, and patient navigators, and you're bringing in the hepatologist or the hepatitis C, the liver specialist, in order to be able to actually prescribe the treatment. We're using something called the stepped wedge design, which it means because we really couldn't, from an equipoise or from the institution, from the idea in clinical research that both interventions should be equal. I don't know that we can really a priori state that telemedicine is not better than referral. This group, I would imagine, would appreciate that and would endorse that. But so basically, each site is going to be doing referral and will be doing telemedicine at some point. We've actually recently completed the usual care arm, and we're now moving to the telemedicine arm. And I'm happy to say that we're actually going to start, I'll actually start the telemedicine evaluations this week. We already have patients who've been screened and who are ready to be evaluated. So I think what I've shown you is that telemedicine-based hepatitis C care is a feasible, it is reimbursable model for hepatitis C treatment delivery in an opioid substitution program. We found in our pilot study excellent patient acceptance that improved over time and excellent treatment efficacy. I mean, 93% were cured of the virus. The substance users prefer to really like the one-stop shopping. They like the convenience of the co-located medical care, and really privacy was not an issue. But what is an issue still is stigmatization. So how do we get this to move on or get more patients to be involved? And our patient partners told us that there's issues with getting people to come to terms with the fact that they have hepatitis C infection. But I think other interventions are needed to develop that. But in this case, I really believe that hepatitis C is a tool. And if we can do it for hepatitis C, we can do it for addiction, we can do it for HIV, diabetes, other diseases that require specialty knowledge. And I think really the implications are to create a financially sustainable telemedicine-based model. And you really need engagement of this vulnerable population, both at the site level as well as the patient. And as we just heard, as the last speaker indicated, I think we have the feasibility to reach rural areas. Once the broadband is there, the doctors and nurses and others can really follow with telehealth. And so with that, I'd like to just thank my collaborators here at Buffalo, START Treatment and Recovery Centers, Dr. Lawrence Brown, and financial supports. And thank you, and I'm happy to take any questions.
Thank you, Andrew. Very informative, and it just goes to show how important telemedicine can be from a convenience and access perspective. So thank you for sharing the work that you're doing with that. I have a couple of questions here, so I'm just going to open the line here for Lowell. So Lowell, your line is unmuted.
Okay, thank you. A few questions, and I'm in telemedicine industry, but also been in the long-term care sector and treated methadone-dependent patients in nursing home environments for many years. When you say the reimbursability, is that limited as in other areas of telemedicine right now to rural only? I see you working in New York City areas. So, in city areas, if a patient's residing in a nursing home and wants to avail themselves of your services, is that reimbursable to you as the provider? That's question number one.
So that's an excellent question. So 3.5 years ago, when we started this project, I met with the medical directors of the three programs of three major insurance companies, and all of them agreed to reimburse for telemedicine. Most of these patients are Medicaid or managed Medicaid. So in this situation, even though the patients may be in an urban area, I think the ability to access healthcare or their willingness to access healthcare is can be viewed as if they were in a rural area as well.
Okay, good. And also, is it strictly, we do have residents still in skilled who come in not on methadone maintenance, but on methadone for pain. Would the same criteria be available for those patients who are, again, not on methadone maintenance programs, but on methadone for pain to avail themselves of these services as well?
Yes, I mean, what we're doing now is really in the context of the study, although we do look for ways to, expand this over time. So yes, I mean, the idea is to take advantage of the methadone programs initially, right, to hopefully prove what we seek to prove. But again, the goal would be eventually to open it not only to methadone, but also to buprenorphine or other types of substance use treatment, as we were discussing using, I think OASAS is also interested in expanding these kinds of interventions to treatment of addiction as well.
Right. That was my next question. It's Suboxone and buprenorphine. The clients have the same potential side effects and the same monitoring. And also, have you dealt with any community-based organizations? I'm not going to name the board, but I sit on a large not-for-profit outpatient mental health program where we have now about expanded by license to 14 sites for methadone dependency and chemical dependency programs. Are you able to work with a community-based organization on this project as well?
Yes, we are. I mean, the programs that have joined us really range the gamut from those that are run by academic medical centers like Mount Sinai, which bought Beth Israel, Strong in Rochester, University of Rochester. The programs here, for example, DART, which is the Community Action Coalition of Erie County, which runs that program, and also hospital-based, so Krause Hospital in Syracuse. So we have the entire, Start Treatment and Recovery Centers is a community-based organization. So yes, we have the entire gamut from those that are affiliated with academic health centers to those that are community-based as well.
Okay, great. And hopefully we'll have your contact information sent out to us. Thank you for the answers and the presentation.
Sure.
Excellent. I don't see any other questions at this time. So I'm actually going to turn it over now. We do have someone from the Department of Health on the line. So many of you remember Ray Ann Aguilera. She was our contact at the Department of Health for many years. She has since moved on to a different department, but we have Megan on the line, who is, quote unquote, the new Ray Ann. So Megan, your line is unmuted. Feel free to introduce yourself to the group and provide us with any updates as they pertain to telemedicine with your division, potentially an update on when a new Medicaid update might be coming out.
Yes, great. Hi, everyone. This is Megan Procorum. I am new to overseeing the health initiatives at the State Health Department. The big news from us is that an expansion in the definition of originating site, so that's where the patient is located for telemedicine and other telehealth modalities, has been expanded for under the telehealth parity law. So this is specific to reimbursement through Medicaid fee-for-service. So currently, right now, private insurance carriers, Medicaid managed care, there aren't as many restrictions on reimbursement depending on where the patient is located. It depends on individual plans, and one would need to check the individual benefit coverage for commercial insurance and Medicaid managed care. But currently under Medicaid fee-for-service, the patient needs to be located in a medical setting licensed by the state. So this is proposed to be expanded through statutory language change as part of the governor's budget bill. So that's some exciting news. We don't expect any stakeholder resistance to this, and I think it'll help immensely with access and reimbursement. Medicaid update is still pending. Unfortunately, I don't have any news on an anticipated release. As you all probably know, this policy update has been anticipated since the parity law was amended and enacted a few years ago, but things just keep changing so rapidly, and our Office of Health Insurance Programs has really been working hard to make sure that the fees for the different modalities for reimbursement are on par with what other states are doing, but things that just can change so quickly. And the update will also include things on patient confidentiality and patients' rights. So, kind of to help providers maintain those things. So we're still awaiting that, and I will make sure to tell everyone when it is finally posted.
Thank you, Megan. Quick question about that originating site expansion, which is very exciting news. What exactly will that entail? I know that the current Medicaid fee-for-service, of course, there are some restrictions on where the patient needs to physically be. Is that originating site expansion going to go so far as allowing the patient to present in their home, or what does that entail? Can you speak to that?
Absolutely, yes. So there will essentially be no more restriction. The originating site will be wherever the patient is located. So they could be at home or any other place of residence. They could be at work. They could be at any other non-licensed community setting. So this is very exciting.
Yes, that is great. I'm sure there's a lot of people on the line that are very excited to hear that. And I apologize if you already mentioned this, but any ETA on when that expansion will be written into law?
So it is the proposed statutory language changes is part of the governor's budget bill, which will hopefully be passed April 1. I do not have the date for when it would be going into effect, but I don't anticipate it being a long length of time.
Okay, excellent. I do see a hand raised by Jeffrey McIntosh. I sent you your PIN. In the meantime, there was another question that came through. Is this just for Medicaid fee-for-service originating site expansion, or is that going to go into law for managed care and private insurers as well?
That's correct. It is right now. It's the way that the law is written. That language restriction only applies to Medicaid fee-for-service. So currently, under insurance law, there are no restrictions. It is just up to individual plans on whatever they would have covered face-to-face. Also needs to be covered through telehealth modalities. So if there are issues in terms of people not being reimbursed for services that otherwise would have been covered, in my new role, I'm looking into what avenues do we have to kind of rectify that because it doesn't seem to be meeting our those standards. The Medicaid managed care plans have all submitted an in lieu of service telehealth innovation projects, or the TIPS. So here they are proposing specific programs on how to use telehealth where the originating site restrictions wouldn't necessarily apply, and could include non-clinical settings of where the patient's located. Those were due into the department December 1st and should be posted to the department's website, so you'll be able to see which plan has proposed what project.
So that will be up on the site soon, you said?
Yes. So, and plans were incentivized to submit those plans. So we should see some good proposals for those.
Yes, I've been certainly awaiting the outcome of that. So that's exciting. So lots of great news coming from the Department of Health. So thank you for hopping on and sharing that with us. I'm not seeing any other questions for you, Megan, at this time. So thank you for that update. And I will build that into the meeting notes so that everybody's made aware of that upcoming originating site expansion. I think a lot of people will be very happy to hear about that.
Great, thank you.
Okay, moving on, I have several updates for everybody. First and foremost, many of you probably saw that AHI is putting on a telehealth webinar series. I will be sending out the links for registration for that in the meeting notes later this week. Session 1 is going to be on Tuesday the 30th, a week from tomorrow, and that's going to be on Telehealth 101. So I'll be addressing some common definitions and modalities of telehealth, answering some frequently asked questions, as well as revealing some commonly held myths about telehealth and what the current reality and state of that is. And then Section 2 will be on Tuesday, February 13th. And that one will be all about billing and reimbursement and how you can get paid. We have a good amount of folks registered already, but I will send out that link. There is no cap on who can register, so feel free to pass that along to folks in your organization if they're interested. Next, I don't know if anybody had the chance to look at Governor Cuomo's State of the State book, but he mentioned telehealth in his plans for the future, and his statement in the State of the State book, it's quite large, it's 376 pages, but he talked about the fact that telehealth can be an important and effective tool in bridging the access gap, yet healthcare providers in rural areas still face resource constraints across programs, impeding their ability to make the investments necessary to support programs like telehealth. and expanding access to care. So to continue to build on New York State's historic progress in increasing access to health care, the state will take a series of steps to modernize the delivery of telehealth services and ensure that rural New Yorkers have access to the care they need when and where they need it. So first and foremost, there will be legislation proposed to ensure that New Yorkers covered under the Medicaid program can receive telehealth services in a wider range of settings, including from their own homes, which Megan just touched on. Under current state law, outdated statutory barriers restrict the settings in which patients can access telehealth services. And under new legislation, a patient may receive telehealth services wherever they are located. The state will also launch a new pilot program to address the resource constraints that many rural healthcare providers face. And this pilot will support rural providers across the state of New York, enabling them to make the necessary investments in telemedicine equipment and IT support to bring healthcare to rural New York. So that is certainly exciting to hear from the governor himself and to have Megan be able to back that up. Next up, there were some Medicare physician fee schedule changes for 2018. Importantly, physicians can now be reimbursed for remote patient monitoring under Medicare. And what they did was they unbundled from current CCM codes, and there's a CPT code now, 99091, which will pay providers $58 per patient per month for a minimum of 30 minutes of monitoring. So that's certainly exciting news from Medicare, as the previous reimbursement was bundled into other codes and it was not ideal for providers. So we're hopeful that remote patient monitoring will see an upswing in that. Next up, an update from the Northeast Telehealth Resource Center. The Northeast Telehealth Resource Center Conference is on June 5th and June 6th in Portland, Maine. There will be more info to come very soon from Andrew and the team there, and including a call for presenters. So when I see that, I'll share that with the group. And lastly, our next telehealth learning collaborative, as you know, we're moving to an every other month format. So there won't be a learning collaborative in February. It falls on President's Day anyways. So March 19th at 2 p.m. will be the next learning collaborative. We are still looking for presenters for that call. So if you are interested, please reach out to me. My email is kcook@ahihealth.org. And I'll turn it over to Bob if there's any updates from the Fort Drum side.
Thanks, Katie. Yeah, the Fort Drum side is working on a couple of programs, but I'm not ready to go into the details of that. So we've fleshed it out with our payers. So I'll have that for everyone on the March call. But we do have a diabetic retinopathy program that we're looking at, and a telehealth sleep lab program that we're looking at, and I'll provide that information on our next call.
Excellent. Thanks, Bob. I don't have anything else for the group, so we'll wrap it up for today. Again, make sure that you register for March 19th. It should hopefully already be on your calendar, and look out for meeting notes and links to the recording and slides in the next couple of days. Have a great week, everybody, and have a good day. Bye-bye.